Hello, WM friends around the world. Welcome to the 6th IWMF Global Educational Webinar. I'm Lisa Wise, and I've lived with WM for the past 11 years. The IWMF has been by my side every step of the way. As a board trustee, I help coordinate support groups worldwide, and I'm the support group leader right here in Philadelphia. Can you feel all of that WM energy buzzing in the air today? That is because a total of 903 people have registered for this webinar from 27 countries in 24 different time zones. We received a record 230 questions from you all. We want to thank you for all the questions that are coming in the Q&A box now, and we hope you understand that we hope your question will be addressed through the pre-submitted questions that we will be asking. We want to thank you for being a part of this important program. It feels really good to come together because this has been a very painful and challenging year with such profound loss and global suffering. Looking ahead, the promise of vaccines are a hopeful light at the end of this pandemic tunnel. But we still worry, what does this mean for us WMers? Is the vaccine safe? Is it effective? Can we leave home? Can we hug our grandkids? The hundreds of questions that were submitted reveal our understandable worries, our concerns, and our anxiety. What we need is clarification, guidance, and warm wisdom. Well, folks, you've come to the right place. Although we may not have access to all the answers yet, we are all in this together. So sit back, get comfy, and enjoy this fireside chat with two WM rock stars who rock our world and need no formal introduction, for they are most beloved by our WM family. So I want to hear you all. Join me loudly from your living rooms across the globe to warmly welcome Dr. Stephen Ansell of the Mayo Clinic in Rochester, Minnesota, and Dr. Jorge Castillo of the Bing Center at the Dana-Farber Cancer Institute in Boston, Massachusetts. How lucky are we to have both doctors answering your questions today about the COVID vaccine and how it affects WM patients. We are most grateful to these doctors and cannot wait to benefit from their sound advice. Welcome, Dr. Ansell. Welcome, Dr. Castillo. Would you like to offer a 1-minute opening statement before we move on with our 35 questions today? Dr.
Sure.
Castillo? Oh, Dr. Ansell, great.
Oh, Steve.
Hey, don't mind. Go ahead, Jorge.
Oh, all right, not a problem. I mean, come on. You know, Steve can speak before me any day of the year. That wouldn't be a problem. So, I mean, thank you very much, Lisa, for the kind introduction. As you said, this has been a very difficult time for all of us, for our families, and to try to stay safe as well. So I think Steve and we will try to provide, guidance and so far what the things that we know and the things that we do not know about the vaccine for the COVID-19 and how we can play our small role, each of us, in trying to protect ourselves and protect the people that we love the most.
Thank you. Dr. Ansell.
Well, just agreeing with that, I think for all of us, things have been challenging and trying. I think it's been very difficult as we've seen people with WM get sick and some who have been at risk for passing away. And it is a really blessed time at this point as we see the vaccines now becoming available and an opportunity for the whole pandemic to change and turn around. So as Jorge said, our goal today is really just to talk clearly about vaccine safety, vaccine expectations related to Waldenstrom's patients, and specifically really try and make sure that everyone is as informed as possible, because for every one of us, as you pointed out, we like to see the back of this whole thing. We'd love to see ourselves being able to interact with our families and friends and obviously do it all in a very safe way. So thanks for having us as part of the panel, and we're happy to take the questions to the best of our ability. Again, I want to just stress as we start out, we are going to offer our best advice. but I want to stress that it's advice and it's our best because it's not going to be perfect. This is a field that keeps changing, and the actual data in WM is not there, so we're extrapolating from other things.
Excellent. Thank you so much. We appreciate both of you setting the stage so beautifully, and I think we're ready for our first question. This comes from Betsy in Berkeley, California. What are we to make of the fact that these vaccines have not been tested on immunocompromised people? So right out of the gate, Dr. Ansell, would you like to jump in?
Yeah, so I think this is a really important question, and you heard me allude to this a little bit when we were sort of starting off with some of our introductory statements, because quite honestly, the clinical trials have predominantly, almost exclusively now been done in healthy volunteers, healthy people, because the idea is to work out what's the best and the most robust immune response that can be obtained from each of these vaccines. So the question is, does it, in an immunocompromised patient have, number one, the same degree of an effect, or number two, any different effect, and potentially, as we'll talk about more, I'm sure, potential more side effects? And so I would say, realistically, when you're immunocompromised, we have to look you straight in the eye and say the likelihood of you having 100% response or 95%, depending on the trial, is probably not accurate. The sooner you, or the closer you are to treatment, the more active your disease, potentially the more compromised your immune system, and the less likely you are to have a response to treatment, to the vaccine. But I would stress, you did not hear me say no response. Definitely there's going to be a response. Definitely that response is going to be less than zero. So not getting the vaccine guarantees zero, but we think that getting a vaccine would actually increase the likelihood of an immune response. And obviously, if you and your family around you are all vaccinated, that really limits the ability for the virus to make you sick or to be passed on or to replicate. So again, I think not being specifically tested in immunocompromised people doesn't mean it's not a good idea. I'd love to hear what Jorge says.
Yes,
yeah, I mean, this is obviously...
Yeah,
so this is obviously one of the most important questions. And from what I understand, I mean, there have been a small group of people with blood cancers and other cancers that have been included in these clinical trials. But they're just, we're talking about patients. The trials are about 20, 30,000, participant trials. Very few hundred patients have had a history of a cancer. The problem is they don't tell us which type is it. They don't tell us if the patients were on active treatment or not. And so we don't have a really good understanding of what happens to that specific group of patients. Having said all that, I agree fully with what Steve said. I mean, I agree it might not be 100% benefit, but I don't think it's going to be a 0% benefit either. So the true number lies somewhere in between, and some protection is better than no protection.
Thank you. Thank you for that critical piece. Some is better than none. Matt, I think we're ready for the next question. Wendy from Cold Spring, New York asks, if the vaccines now available were never tested on people with compromised immune systems, how can we really be sure they are effective and, most importantly, safe? Is it possible there could be some unknown dangerous side effects for such patients later on down the road?
Yeah, so I can go and answer this question. So obviously, part of that question was answered in the prior question. No, I mean, unfortunately, I don't think we can be completely sure. And really be sure is a very strong statement. I think we can make assumptions based on what we know. Now, that's based on efficacy. Now, in the terms of safety, we have not seen any specific area of safety issues, at least with this vaccine, with the types of vaccines that we're seeing. Now, the two types of vaccines that were approved initially, the Moderna vaccine as well as the Pfizer vaccine, they use an RNA method of producing an immune response that is, not the typical, system that is used for vaccinations previously. Having said all that, by the understanding of the biology of how it works, these RNA pieces are not going to, insert themselves into your genome. That is not something that happens. that is not going to, promote the development of other cancers. I mean, that is just not the way this works based on how we understand the vaccines actually work. So I cannot tell you that we know what happens, because obviously we have more long-term data to understand what happens in the future in terms of dangerous side effects, but we are not expecting any dangerous side effect, at least from that perspective, just based on how we understand the vaccines work.
And I would just totally agree with what Jorge is saying, because it's interesting, millions of people have now been vaccinated. So actually this body of evidence is growing dramatically. So could there be additional side effects that we have not anticipated so far down the road? That's possible. But now we have, many months and many millions of people vaccinated, and you're not hearing on the news about dramatic bad side effects that are coming up. There's always a reaction. People are having natural reactions to the vaccine, and you want that because it tells you that your immune system woke up and paid attention. And that was exactly the point of the vaccine. I also think it's really important to say everything at this time is about risk and benefit. So quite frankly, we've got COVID-19 on the one hand, and very good evidence, lots of it right now, that if you have a blood-related cancer and you actually get sick from COVID-19, that is actually quite hazardous to your health. And there is a high likelihood of getting very sick. And there's a significant likelihood possibly even of passing away. So clearly that's a present and very real risk and danger, and a major side effect, if you like. On the flip side are the vaccines. And again, yes, they might have some immediate side effects as you react to them, and potentially there could be something down the road, but that appears very rare. But if you weigh those two up, you have to say that the COVID-19 infection weighs much, much more dramatically than the vaccine risk. And so I think if you put those next to each other, I would say in my mind, there's really no contest about which direction you should be thinking you should go.
That's so helpful. Thank you very much for the clarity of those responses and the reassurance as well. Ronald from Glen Cove, New York asked, which types of white blood cells do the vaccines train to disable the coronavirus? And do WM patients have enough of these types of white blood cells to make the vaccine be effective?
So I can maybe start with that one, if that's okay, Jorge.
Please.
So in general, if you just think about how your body responds, as the virus or the vaccine kind of engages with the immune system, typically what they call antigen-presenting cells will show that protein, in many cases this is the spike protein, to the immune system. And what typically happens are you make antibodies, number one, and you get a T-cell response, number two. So the antibodies is a little bit like the Air Force getting scrambled and the missiles being shot out, and the T-cells are like the infantry or the Green Berets, the hand-to-hand combat part of your immune system. So actually, both of those become activated. So in general, if you take a person with Waldenström's who may even be on treatment, you would actually say components of both of those are still active and still available. Now, fair enough, when you get rituximab, you typically can directly deplete deplete your B cells and potentially your ability to make antibodies. Similarly, if you get chemotherapy drugs, you can have an effect on your T cells. If you get ibrutinib, you can have an effect again on your B cells. So there can be effects between all of these sides, but most treatments do not entirely obliterate everything, and your immune system is able to bounce back quite quickly. So if you allow a little bit of time, even just a few weeks from your most recent dose of treatment, you may still have an adequate immune response to the vaccine. Is it going to be perfect? We said early, probably not. But on the other hand, it's certainly going to be better than nothing. So I would say that my view is you probably have sufficient cells to actually make the treatment the vaccine have some degree of efficacy. Jorge, what do you think?
I fully agree with your statement.
Thank you so much. Is there anything you want to add to that, Dr. Cassie? Are we ready for the next?
No,
Great.
It's all good.
Okay. And I'm keeping note. So we've heard twice now that some protection is better than no protection. And I want to be sure that we are clocking that critical point since I've heard it now twice. There's a series now of 3 ibrutinib-specific questions. The ibrutinib-specific questions were asked by many, many people. There was a lot of interest in this. So we'll go through them one at a time. I have a low number of white cells and continue to be treated by ibrutinib. Can I or should I take the vaccine?
Yeah, and again, that's a very good question. Yeah, happy to answer. So, I mean, there are different types of white blood cells. I am assuming that this patient is inquiring about probably a low number of neutrophils or maybe a low number of lymphocytes, which are the most common white blood cells that we do have. However, I mean, basically piggybacking on what Steve said a minute earlier, there are many ways in which these vaccines actually activate your immune system. They use B cells, T cells, and others. So the fact that you have a lower number of white blood cells per se should not be a reason or a contraindication to actually get the vaccine. So I think the short answer for that question is, can I? Yes. Or should I? Yes. Take the vaccine, for sure.
Excellent. Dr. Ansell, want to add anything before we go to the next?
Nope, that's well covered.
Fabulous. Complete agreement. I love it. That makes it easy. Can the vaccine interfere with treatments for WM patients, specifically ibrutinib?
So I can go with that. And the answer is yes, because quite frankly, you want to have a perfect immune system, to have a perfect response to a vaccine. In fact, it's really interesting. Some data that just came out yesterday that I saw was studies now done in 12 to 15-year-olds showed that the number of them responding and having an adequate protection seemed to approach 100%. Well, why am I not shocked? Young people, in excellent shape, immune system is totally perfect. They respond really well. As you get older, that number goes down just because you got older and your immune system is a little more worn out. Obviously, add on top of that a malignancy, add on top of that again a treatment for the malignancy. Those will all interfere to some degree with the ability to mount the immune response. But as we pointed out now a number of times, and we'll probably say again, that immune response is not zero. And that's better than it would be if you didn't have a vaccine, in which case it would be guaranteed to be zero.
Excellent.
Yeah, I think something I would like to add is that, sometimes patients ask, should I stop ibrutinib, and they might get my vaccine to guarantee that I'm going to get a better response. We don't have any data to suggest that actually improves the response to the vaccine. There are some potential issues on stopping ibrutinib, withdrawal symptoms, and things of that nature, IgM spikes. I do not believe that is something that should be a practice in patients taking ibrutinib. So just wanted to add that.
I agree.
Oh, excellent. Thank you for that. And the last question about ibrutinib. I'm currently on ibrutinib for my WM. Does ibrutinib have an impact on the effectiveness of the COVID vaccines? Just to be sure we've heard it right.
Yeah. So, I mean, I think we addressed this specific question previously. It may, it might. Having said all that, not a contraindication to actually get the vaccine.
Thank you. Matt, I think we're ready. Laurence from Philadelphia, PA, asks a question that Dr. Ansell just referenced earlier today, so maybe we could drill down and unpack that together. He received both Pfizer COVID vaccines and had a slight headache at night, but no other side effects. If he doesn't have side effects, does that mean that his immune system did not kick in and he's not protected? I've heard this question from many, many folks who are concerned that they're not getting sick enough from the vaccine for the vaccine to count. What would you say, Dr. Ansell?
Well, I think so. One of the things that I think is quite informative is if you think about vaccines that you've received for other infections and viruses and the like. There are some that are notorious for giving more symptoms and some that are notorious for giving less symptoms. But at the end of the day, they pretty much all of them do their job and have a degree of good efficacy in preventing you from getting the illness. So I think bottom line is so far, you'll notice there are different side effects from the different types of vaccines. And I don't think the actual degree of your side effects is proportional to the efficacy and the protection that you have from the vaccine. And the further reason to say that is that if you look at the data from the randomized clinical trials and you look at the percentage of people that actually had symptoms and the percentage of people that had protection, the percentage of people with symptoms was quite significantly lower than the degree of protection that was seen. So I think all told, that just says you don't actually have to get side effects to get symptoms. If you're getting symptoms, it's clearly, you don't have to get side effects to know that it's working. But if you're getting symptoms, it probably means it is working because of the fact that your immune system is more active. But it's not exactly a one-to-one correlation. So I would just say, all told, we don't want people to have too many symptoms so that they don't want to get the vaccine. But I don't think, on the other hand, that you should be anxious that your vaccine's not working if you didn't feel horribly ill.
Thank you. Dr. Castillo, would you like to add to that?
Nothing to add to that.
Brilliant. Thank you. Charles from Jacksonville, Florida. How does the effectiveness of the vaccines correlate with serum IgG or IgA levels? If my serum IgG or IgA levels are low due to WM, would that prevent my immune system from protecting me against COVID? What do you think, Dr. Castillo?
Yeah, so I think the short answer is probably no. Probably doesn't have a major, effect on the effectiveness of the vaccine for us to consider that a patient with low IgG or low IgA should not get vaccinated. A number of reasons. There's a lot of IgG and IgA that is actually deposited, in our tissues rather than floating in the bloodstream. Just to give you an idea. And the other aspect of things is, IgM is important for an immune reaction, IgG is important for immune reaction, but those are not the only factors that are needed, necessary, or mediate an immune reaction to a vaccine. There are many other factors that we were talking about. So that alone should not be, for me, a criteria not to move forward with a vaccine.
I would agree with that completely. I think if you really have very low levels, I think we have to be a little more careful not to say you're going to have a perfect immune response, because it might suggest your immune system has taken a bit of a beating from things that have happened recently. But to Jorge's point, I think is no reason why you might not have at least a degree of protection. And so that would not be a contraindication at all to get the vaccine.
Excellent. Thank you both. That's very helpful. Cathy from Cedar Rapids, Iowa asks, what is the vaccine effectiveness for patients currently undergoing Rituxan maintenance therapy? Should Ritux be stopped to elicit a stronger immune response to the vaccine? And if so, how far in advance? What do you think, Dr. Ansell?
Yeah, so again, we've touched on this a little bit, but maybe just to expand on this, and then I'd love to hear Dr. Castillo's thoughts as well. Quite clearly, the rituximab is going to decrease B lymphocytes, which are the cells that will turn into plasma cells and make antibodies. So would it be helpful to have more B lymphocytes around? Possibly. Could you not just make a whole bunch more in response to the vaccine threat? Yes, but exactly the optimal time has really not been tested. So we have very little data to understand this. So theoretically, if you delayed the rituximab treatment or stopped it for a while, that would be helpful. We know that it takes about 6 months for you to get your B cells coming back up again after rituximab. The problem I see is, do you really want to wait 6 months while COVID flies around in your neighborhood and have zero protection? Would it not make more sense to say, I'll take the fact that it's less than ideal, but I have some, and I'll strongly encourage my family and friends to get vaccinated, in which case they will protect me by not giving me the infection. So we've tended to recommend to folks that that's one of the strategies to adopt. I will say this much, that maintenance therapy, I think, is a debate that one could have, and discussion you could have with your doctor about the merits of that at this point, because remember, maintenance is doing exactly that, maintaining the benefit you've received from treatment before. So if you have a really stellar benefit from treatment before, you may be able to have a period now where you don't actually need to be maintained in that circumstance, in which case that might be a reason to consider stopping the rituximab. On the other hand, if you say, well, the problem is my disease actually was not all that well maintained and it's still kind of lurking, then it may be necessary for you to be getting rituximab as part of your treatment. And then the part of what I said earlier would obviously be relevant. But I'd love to hear what Dr. Castillo and what the group at Dana-Farber are doing.
Yes, so I mean, I agree with you. I mean, the current position, not only by us, but also by the American Society of Hematology in the Waldenstrom's workshop, is to avoid rituximab maintenance if it's not absolutely necessary. So in patients who have great responses to therapy, we are actually, in the context of the COVID pandemic, I think we are recommending, not moving forward with maintenance in many scenarios. So I think this is going to be a conversation to be had between the practitioner and the patient in terms of moving forward with a rituximab maintenance or not. But I agree, I don't think there's a time that is clearly defined on when it's best to get the vaccine after a rituximab infusion. But I think at any time of getting it is better than not getting it.
Thank you very much, doctors. I think we have another Rituxan theme. Silvano from Miami, Florida asks, if on Rituxan, do you need to be off for 90 days before being vaccinated? I'm currently taking treatment every 8 weeks.
Yeah, that sounds like a maintenance to me. So basically, what we talked about in the prior question would apply to this question as well.
Perfect. Okay, great. Thanks, Matt. We can move on to the next one. Are there any special concerns about the vaccine for patients with Bing-Neill syndrome? Dr. Castillo, would you like to take that?
Yeah, I'm happy to take that question. So, I mean, we don't have any specific concerns in patients with Bing-Neill syndrome that is different of the concerns that we will have with a patient with Waldenstrom's who are actually undergoing treatment. So I don't have anything special in that specific context.
Dr. Ansell, anything to add?
No, I think Dr. Castillo said it all. I think it's all about the treatment rather than the syndrome.
Yeah.
Agreed.
Okay. Very helpful. And I just want to mention that for our Bing-Neill patients, that the IWMF has a new international support group available for Bing-Neill patients. And if you're interested in that, please go to our website at IWMF.com so we can connect you to that wonderful supportive resource. Sheila from Germantown, Wisconsin asks, are there any special concerns about the vaccine for WM patients with autoimmune conditions? Dr. Ansell?
I think, again, a lot of people with autoimmune conditions are part of the rollout of vaccinations, and there has not been a significant toxicity signal that has come from any of the studies related to that. I mean, could you make up some theoretical concerns? Sure. You're maybe activating an immune system that is more sort of sensitive to being autoreacted. So, yes, it could have an effect. However, to date, that really doesn't appear to be the case. And I think the main reason actually is that you're specifically stimulating the immune system toward one antigen, one foreign protein, mainly the spike protein on the virus. So it stays pretty focused. So there's a little bit of data you could argue that immune thrombocytopenia is an autoimmune type of thing. And there was some data to say that people with low platelet counts from an autoimmune reasons may have some increased risk. But remember, that's just been, a few dozen patients of the many millions of people that are getting the vaccine. So I think there are always things to be aware of. And I think that's why they give you the information to say, please call if you have these side effects. Please, they make you sit for a little bit to make sure nothing's going on, because obviously folks want to be careful. But I don't see this as a reason not to proceed.
Fantastic. Thank you, Dr. Ansell. Very helpful. We have Jane from Loudonville, New York. Could the doctors talk about coronavirus variants and the possible need, therefore, for booster shots? We've all been hearing talk of this third shot or what we might need in the future. Anybody have a crystal ball they want to pull out?
Yeah, so nobody has a crystal ball. I don't think anybody has a crystal ball here, but I mean, so there have been 3 well-defined variants, and they all have their own specific names. But, for simplicity, we're going to call them the UK variant, the Brazilian variant, and the South African variant. There are 3 more, actually, the Los Angeles variant and the New York variant that are under investigation currently. So how much do we know about, what these variants actually are and how they behave? It seems that some of them are actually more contagious than the regular, virus that we knew. Some of them seem to affect, the immune systems a little stronger in other places. But again, most of this data is not data from the United States. This is data from outside of the country, and obviously there are specific differences in terms of the populations from other places and ours. There are currently companies developing booster shots for the variants. That's as far as I know. But obviously, none of these booster shots have been approved yet. There's going to be a lot of research that needs to be done for these to even be considered. At this time, we don't have any data that any action needs to be taken in that for prophylaxis specifically. We should continue, obviously, wearing our masks and avoiding crowds, even if you get vaccinated, because at this time it is unclear what the benefit of the actual vaccine is for prevention of a variant's reinfection or an infection.
I would totally agree with that, and I would say, I wouldn't be shocked, putting my crystal ball, which I also don't have, but this is my guesstimate, is I would not be shocked that similar to influenza vaccines, you need to get a new one each year as things change. Because again, think of influenza, it changes its nature a little bit every year, and they just track it around the globe and keep tweaking the shot to try and make sure they cover the degree of change. And so I think I see us right along with an influenza shot, getting a COVID-19 shot, if not every year, every other year. I'd say one other thing that I think is important for people to remember: you can't get a variant if you don't have a virus that's replicating. So if the virus doesn't actually try and make copies of itself, it doesn't mutate. So that speaks to everybody getting a shot, everybody preventing the infection, because if the infection stops making people sick, variants go away.
Oh, fabulous. Thank you. That was very motivating. Thank you, Dr. Ansell. Cathy from Pacific Palisades in California asks, how likely am I to be allergic to a COVID vaccine? I have many allergies, some severe. Many WMers are special sensitivity cases where, they've had reactions to medications, immunotherapies, et cetera. What do you say to all of us who are a little bit hyperreactive in the sensitivity area? Dr. Ansell, do you want to kick that off?
Sure. So I think there's a sensitivity and there's an allergy. So I think it's important to know that sometimes people react to a lot of things, but an allergic reaction is an immune reaction that is pretty dramatic and that can be anaphylactoid in nature. And that's hazardous, and that's very uncommon. So again, that's not something that's typically seen. And if it happens, that's why they make you wait for 15 minutes to make sure that doesn't happen. You just basically sit at the place. But some people may have other degrees of reactions, and the reactions are mostly to some of the things that are suspended, that the vaccine is suspended in, and that's why when you fill in your questionnaire, they ask you that. But I would tell you that most of the time, you're not going to be allergic to the actual vaccine part. That part is actually RNA code, or is in the case of Moderna and Pfizer, and you can't actually be allergic to that because that's like being allergic to your own DNA. That's not actually feasible. So all told, I would say that I think there are possibilities for reactions. I think they are uncommon. I think most places have a good strategy to watch for that. And in my mind, that should not be a reason not to consider getting the vaccine. I don't know, Jorge, what do you think?
Yeah, no, that's for sure. I mean, some people will be allergic to some things, and that is true for every vaccine and any medication and every other compound that is being used. But I do not believe that if somebody's, let's say, allergic to rituximab, then they will be allergic to the vaccine. I cannot say that if somebody's allergic to, penicillins, they will be allergic to the COVID vaccine. They are completely different molecules, completely different chemical compounds. So yeah, I agree. I mean, even if you had a history of allergies, that will not preclude me from recommending the vaccine.
Thank you so much, doctors. I appreciate that. Karen from Mohnton, Pennsylvania asks, I've read articles on miscarriages after vaccination. How accurate are these? Is there a protein in the vaccine that affects the placenta in young females? Dr. Castillo, have you heard of this?
Yeah, no, actually I haven't. I think we have heard a little bit of clots with the AstraZeneca vaccine, and that's, put on hold a little bit the development there. Some concerns about, ITP, extremely rare, in the 1 in 1,000 or 10,000 cases that I'm aware of. I have not really heard much about miscarriages with the COVID-19 vaccine, so I don't know where that question is coming from. Trust me, we have seen that will be making news. So I don't know.
Right.
Yeah, I don't know really where is that coming from, honestly.
Thanks.
Yeah,
Dr.
and I must
Ansell,
say, no, I just think I'm with Dr. Castillo. I don't know that there is a lot of data, and this might just be kind of like word of mouth and some discussions. And I think what's really important is just to be sure that if there are miscarriages, it isn't just something that is a very unfortunate event at the same time as having COVID or getting the vaccine. In fact, there's some data from Harvard that didn't seem to suggest that there was an increase in miscarriages amongst their prenatal group. So I don't know that we have a lot of data here. And I think that I think there's a far greater likelihood in my mind of having a miscarriage when you actually have the infection than if you're getting vaccinated. Because obviously, as Dr. Castillo said, there's a lot of challenges with blood clotting and the like, which will stress the whole placenta and the fetus. And that's more likely in my mind. I don't know a lot of data that says miscarriages are an increased risk.
Thank you very much for clarifying that, both of you. Meg from Menomonie, Wisconsin. Should I get an antibody test following vaccination? And if yes, which test is accurate? If the test is negative for COVID-19 antibodies, what should I do? This is a multi-part question. Dr. Ansell, where would you like to begin?
Maybe I'll just start with, should you get an antibody test? And I would say no. And the reason you shouldn't is I always believe you got to know what you're going to do with the results before you do a test. So if the test is not going to actually inform anything, I don't know because again, we don't know that the COVID-19 antibody titer or the level correlates exactly with the degree of protection that you have or don't have after a vaccination. So if you have the test and you have very high levels, should you feel bulletproof? Or if you have low levels, should you feel like you need another shot? I don't know that we know that. Now, there are actually trials ongoing right now to really try and clarify this. But I think until we've got that information, I personally would not do it, because I certainly wouldn't recommend somebody get their vaccination over if they didn't, have a good response, or they didn't seemingly have a lot of antibodies. And so if I wasn't going to change what I would do, I wouldn't do the test.
Yeah, just to add some to what Steve said. I mean, I think a lot of the antibody tests were developed to see the response to the infection the patients got. If you got an infection with COVID-19, and then obviously you mounted a response to that, and we thought that maybe those tests would also be as good as to measure the response to the vaccine, but that is actually not true. We are learning that those tests that we measure after an infection cannot reflect very well a response to the vaccine. So as of today, we don't have a good test that we can say, oh, this is the test that you should have, so we know exactly what your response to the vaccine is going to be. So I second what Steve said in terms of, you're interested in knowing, maybe participating in a study that is evaluating those is probably the right thing to do. In clinical care, again, I don't think we do know yet which is the best test, and if it's a positive or a negative, exactly what that means. So what do we need to do about that?
Okay. Thank you very much. I think we have another question or a couple more that are drilled down on this. Lynn from Penfield, New York asks, what does it mean if a COVID antibody test comes back negative after the person has been fully vaccinated? I received a lot of questions from people saying, if it's negative, does it mean that I don't have any protection and that the vaccine does not work?
Yeah. So yeah, I mean, I think that's essentially what we discussed previously. I think with the actual current tests, we understand what exactly that means.
Right. Okay, perfect. Dr. Ansell, if you're comfortable with that, we can move to the next. Can you describe the antibody testing following COVID vaccination done at your institution, and at what point is it done following vaccination? Do you measure neutralizing antibodies or just spike antibodies in general, even if they're not neutralizing? Do you perform testing to assess the T-cell response to vaccination? So clearly someone who would like to drill down on the science here and understand what you're looking for and get a peek into what you might be reporting on when all of this wonderful research is done. Dr. Castillo, do you want to jump in?
Yeah, so we're doing a study at the Dana-Farber in which we're taking blood from patients before the vaccine, and then 3 months later, and 6 months later, and a year later. And we want to be checking T-cell panels, we want to be checking spike antibodies, nucleocapsid antibodies. But again, that is a research study. Patients need to be vaccinated in the Dana-Farber system, so it's going to be kind of limited to a very small group of patients. I know there are other centers doing similar studies too. So again, my encouragement of finding out if they are interested. But I mean, most of these tests, these studies will be more fruitful, when patients get blood before the vaccine and then after.
Yeah, I just agree with Jorge completely, because we do this. We have a clinical study here too. It's kind of for general B-cell cancers. But quite frankly, outside of that particular clinical research project, we don't do any of that analysis in general practice.
Agreed.
Thank you both. We've just passed the halfway mark of our slides. So doctors, with your permission, maybe we'll see if we can do a little bit more of a lightning round feel to our questions, just so we can get through them all, though it kills me to do that. But Madeleine from Lincoln, California asks, are there any trials at present to evaluate the efficacy and response rate of the COVID-19 vaccine in patients with B-cell blood cancers like WM? Dr. Ansell?
So, just as we mentioned, I think both the Dana-Farber and Mayo, but many other places too, there are specific studies in B-cell cancers which specifically are checking before and after to assess the response to the vaccine. And I know the Leukemia Lymphoma Society has also had a strong endeavor in this space. But all of those are still ongoing at this point.
Excellent. Dr. Castillo?
Yeah, I guess, we will not have the readouts on these studies anytime soon. I think this is something we will learn, for the future.
Okay. Thank you. The next question is from Beth in Valley Village, California. Any idea when the FDA will approve a test to determine the effectiveness of COVID vaccines for those of us with lowered immunities? So when the FDA will approve? Boy, that's now we're a crystal ball, right?
Yeah, I do not know the answer to that question.
Well, so I would just agree with Jorge. I don't quite know what to do with that question, because quite frankly, how is this test going to help you? So if you get a vaccine and it says there's a test that says you have a 40% likelihood of benefiting from the vaccine, would that mean you wouldn't take it? I'd take it. I'd take it for 40%. So how about 35? Sure. I take it, so I mean, at what point do you go, that's not effective enough, in which case I'm not going to take it? I don't know the answer to that. If it was 5%, I might still take it. So again, I don't know how I'm going to use the test.
So that's critical, because we're saying some protection is better than no protection. But I wonder if this question isn't leading us to the next phase, which I know we have some questions coming down the pipes, is if I have the vaccine, what can I go out and do safely? So let's see if we're moving into that, because then the question would be, is it effective enough for me to enjoy life somewhat more freely than I have for the past 12 months? Let's see what the next question is. Claudia from Germany, which vaccine is best for a WM patient, the mRNA type from Pfizer or Moderna, or the vector type from Johnson & Johnson or AstraZeneca?
Yeah, I'm happy to take on that. So, I mean, at least in the United States, we have the Pfizer, Moderna, and J&J. I think in Europe, they have 4 of them approved already. I don't think that at this time any patient who wants to get vaccinated can choose which vaccine they want. I think the states or the place where you're going or the institution that you belong to, they have their own contracts and they provide a specific vaccine. Now, there has not been any study comparing these vaccines one against the other. Therefore, I don't think I can safely say that one vaccine is clearly superior than another vaccine. Therefore, the vaccine that you get access to, that's probably the vaccine that you should get.
So I would totally agree with that. The best one is the one you can get your hands on. Right. So I'm all for that. And I also would just point out something that Jorge said that I think bears just saying again. You can't actually compare studies across study. You have to have a study where you have two vaccines in the same study. And the reason is the people that are included. If you have more old people or young people, sick people, not sick people, kids, not kids, it changes your percentage numbers. And so when people say, oh, this one's got 95 and oh, this one's only got 75, that really isn't a comparison that you can really make. The statisticians freak out when you try and say you want to do that. And in clinical trials for cancer research, for drugs, for years we've said, don't do that. And yet here we are with vaccines suddenly doing that. So I would say, be cautious.
Thank you, Dr. Ansell. We're ready for the next question, Matt. Lynn from Albuquerque, New Mexico asks, would the Johnson & Johnson vaccine be something a WMer could take? It has adenovirus that will not reproduce inside the body. Does that mean it's safe for WMers? How about AstraZeneca? I think we've answered a bit of that, but anything to add, Dr. Castillo?
Yeah, I mean, adenoviruses mediated vaccines are, a very common way of generating vaccines for other problems. So yeah, I would not imagine that is a contraindication for a patient with Waldenstrom's. I would recommend the vaccine if it's available. And if the only one that is available, then yes, you should take
Excellent. it. Add?
No, I mean, I think that's exactly right.
Good. Okay. Walter from Indonesia. We live in Indonesia. Is it safe to receive the vaccines from New Crown by Sinopharm, Coronavac by Sinovac, or Sputnik V from Russia? This is an important question for our international affiliates of the IWMF who are represented here by all of our flags on the window. Dr. Ansell, I want to jump in there.
I can certainly take that. So again, the data are coming out on all of these different vaccines, and actually all of them have proven to be quite good. I saw the more recent data from the Sputnik 5 vaccine, and their larger study actually showed really encouraging results. So I think, quite honestly, the main thing is if you have an access to a vaccine, and it doesn't actually, in my mind, matter which, I think it's quite legitimate to go ahead and get it, because if you and all your friends and all your neighbors and all your family get vaccinated, even if the take rate, as it were, in you is lower, you're protected because of this whole herd immunity thing that we're all striving for.
Mm-hmm. Thank you. Dr. Castillo, anything to add to that?
Nope. Steve has said it.
Okay. That's a critical point, Dr. Ansell. Thank you. Dawn from Clarendon Hills, Illinois asks, can I spread COVID after getting the vaccine, or is the viral load too small? Dr. Castillo, what are your thoughts?
Yeah, so I mean, it all depends how we interpret that question. So on one hand, we could say, if I get the COVID vaccine, do I spread COVID because I got the vaccine? That is not the case. We don't spread the infection after as the vaccine has been given. The other way to interpret this question will be, can I spread COVID if I get COVID, even if I get the vaccine, right? So that's another scenario, because people can get infected even if they get the vaccine, right? I mean, the infection rate with COVID after the COVID vaccine is not at 0%. There's a much smaller risk, 95% lower risk, but it's not a zero risk. So yeah, people can get infected with COVID even after they got the COVID vaccine. In that scenario, yeah, you could potentially spread it if you actually are actively infected. But the likelihood of developing a serious infection and likelihood of actually spreading the infection is much lower if you have gotten the vaccine. So, I don't know exactly what this question means, but that will be the two ways in which I could interpret the question and answer it. I provided the answers for both.
I think that's very well answered. That's well answered. I would just basically say that it's important to wear a mask and keep washing your hands and the like.
Excellent. Okay, that's fantastic, and that's going to get us to some of the questions coming up. Craig from Rancho Palos Verdes, California. If you've already received the vaccine, what can you do to enhance your protection? So I think, Dr. Ansell, you're very clairvoyant. So you want to start, Dr. Ansell?
Wash your hands, wear a mask.
Social distance, wash your hands, wear a mask. Dr. Castillo, anything to add to that critical list?
Yeah, so same thing.
Stay away from sick people.
That's right. Stay away from crowds. Mask. Stay safe.
Okay. Here's more of them. Anne from Colorado Springs, Colorado. If I have had 2 vaccines more than a month ago, how much can I go out in public if I wear a mask? People really want to know the specifics here. What's safe? How much? How often? How many times a month? How many people? Any guidelines to offer?
So I think I would just say one thing, and that is it's about risks and benefits. We kind of touched on this earlier. So COVID-19 is the risk. Vaccines and getting with your friends and family are clearly the benefits. And so by getting a vaccine, you decrease your risk. But as Dr. Castillo just said, it's not to zero. So, again, I think you may wear a mask and you can wash your hands and you can be careful around people. That risk never goes down to zero. And I think you just have to weigh up the degree of risk compared to what you're prepared to take on. So if everyone's vaccinated and all your family and friends are vaccinated and you want to hang out with them, your risk is relatively low. And I would say that's something that certainly could be explored. On the other hand, if you want to go to a bar and hang around with people you don't know and let them breathe on you, that's going to still keep your risk up there. So I would say you might just need to evaluate risks versus benefits.
Dr. Castillo, would you like to add? Thank you. That was.
I agree. I mean, I think there's a lot of things that are medical contraindications. I don't think there is a medical contraindication for a patient to go out in public wearing a mask if they have already been vaccinated. I think it's more of a personal decision of how comfortable you feel with the risk. Any activity outside, surrounding yourself by people who you do not know if they're vaccinated or not, even if you wear a mask, represents a risk. So we need to know, the patient needs to feel comfortable doing that. And that's it.
Okay. Thank you both. That risk-benefit analysis is critical. Do you recommend double masking for unvaccinated WMers, vaccinated WMers, or both? So wearing 2 masks, what do you think? Dr. Castillo, you want to start on that?
Yeah, I don't think it's going to hurt people. I don't think there is data suggesting that actually that it is better than just wearing 1 mask. So, if you can afford 2 masks and you don't feel too uncomfortable, I don't think it's something that you should not do or contraindicated by no means. I think it's unclear what the benefit of that is as well.
Okay. Dr. Ansell, anything to add?
No, I think that's well covered.
Oh, fascinating. That's fascinating. Okay. Next question is from Stephen in Escondido, California. After I'm fully vaccinated, is it safe for me to visit my grandkids under 15 years old who have not been vaccinated? And if so, is it safe with no masks? Can I hug them? Let's go one at a time through these because I think these questions are at the heart of a lot of people's concerns and queries. Dr. Ansell, what about visiting grandkids?
So again, we touched on this, and to be honest, you're going to hear this as a kind of a guiding principle. How much of a risk are you, how much risk are you taking on with the people you're intersecting with? So if you know your grandkids have been being pretty responsible, they're unlikely to be ill, and they don't have any symptoms right now, and you go and hang out with them and you're vaccinated and you're welcome to hug them. In fact, I would encourage that. However, I would say, if you know that your kids have been exposed to friends at school and, there's been a lot of COVID in the environment and whatever, then I'd be a lot more careful. And, even when you've been vaccinated, because your risk is not zero. So I think that the point is that this is very individualized and it comes down to the risk of the person you're intersecting with and your risk and putting those two together to determine how much of a risk you're taking on.
I see. Thank you. Dr. Castillo?
Yeah, fully agree. Fully agree with that. Nothing to add.
I think there were a couple of more questions on that last one.
Yeah.
I wanted to get to. Is it safe? Yeah. Is it safe for unmasked vaccinated WM patients to visit other unmasked vaccinated adults? And can I go inside a grocery store, a restaurant, or a gym if I'm fully vaccinated? Should I wear my mask?
Yeah. So for question number 2, I mean, the CDC is currently, saying that unmasked vaccinated people can actually meet with another unmasked vaccinated people. Having said all that, I mean, there is a much smaller risk of contracting an infection that way, but it's not a zero risk. So it can be done, yes. Would you as a person would like to do that? That is a personal decision to be made. With respect of going to grocery stores, restaurants, or gyms and things of that nature, again, I think people can go. They need to be very careful about washing their hands, not touching their face, wearing a mask. Everybody else should be wearing a mask. But again, also represents a small risk on going out and doing this type of things too. So it's all about how comfortable everybody feels with that risk.
Yes, yes. Dr. Ansell, anything to add to the risk?
No, I think it's right.
Okay, thank you. That's very helpful. Adds a lot of clarity. Matt, I think we're ready for the next one now. Jimmy from Canada asks, what is the recovery rate for WM patients with COVID? Is COVID more severe in WM patients than in the normal population? And if WMers get sick with COVID, what's the mortality rate? Dr. Ansell?
Yeah, so I think, again, the data are kind of sparse here. So I think we have to kind of hedge a little bit, and it's difficult to give absolute numbers. I will say this much, that in general, people with blood-related cancers have a lot of risk if they actually get sick with COVID. So that's why you hear Dr. Castillo and I strongly recommending don't get sick if you can avoid it. Most patients, a vast majority, even if they get sick, will recover, and that's good. The problem is long-term effects, long-term side effects, complications, and morbidity. In other words, kind of the lingering effects of the infection may stick with you and actually really impact your quality of life. All told, though, the mortality rate is a little difficult to get at because we've been looking at different populations, who got sick, did they get in the hospital, and so all of those numbers are a little different. And sometimes some of the medications can be protective, and sometimes the medications may not be protective. So I think that's a really difficult question to answer. But I think in the context of today's conversation, in my mind, it is a far better thing to be vaccinated and not get COVID-19 infection than to get it and take your chances with it.
Right. Thank you for the clarity of that point. Dr. Castillo, anything to add?
Yeah, I mean, obviously, as Steve said, the data is very limited. Data are very limited in this scenario. I'm aware of probably about 2 or 3 dozens of patients with Waldenström who have gotten the infection with COVID-19. Having said all that, this is not, a systematic review of all the patients that we have. This is just the people that we know they had them. I mean, most of the patients have been able to, manage the infection at home. When the symptoms have been severe, patients have gone to the hospital, which is the right thing to do when you have moderate to severe symptoms. With mild symptoms, people can get these, antibodies that have been approved by the FDA. That's the recommendation. With more severe symptoms, patients should be going to the hospital. And there have been a couple of patients that have died from our database because of COVID. But the large majority have recovered, from the infection. Again, how representative that is of what's going to happen to everybody with Waldenström's is very difficult because everybody is different. We do have patients who have never been treated. We have patients who have been multiply treated. We have patients on active treatments. So, there's no way I don't think the risk is the same for, all these different types of patients. So, being careful is the thing to do.
Absolutely. Thank you so much, Dr. Castillo. And of course, we send our best wishes out to anyone who is ill, and only good thoughts and wishes. Matt, I think we're ready for the next question. Catherine from Australia asks, is it okay to have the COVID vaccine and a flu shot? How about shingles vaccine, Shingrix? Dr. Castillo.
Yeah, I mean, I don't think there's any data to suggest that we should not get all these vaccines. If you recall, with the people who have babies, they get probably 6 vaccines on each leg, on the same day. Right. Even in the military, right, Steve? People get a bunch of vaccines all at the same time. We don't even blink about that. So yeah, I mean, please get your flu shot every year. If you qualify for the shingles vaccine, if you feel that you will benefit from it, you should get that as well. And your COVID vaccine, definitely.
I think the only thing I would add to that would just be to say, maybe based on all the questions we had before, don't get them at exactly the same time, because then it's very difficult to work out which one gave you the symptoms. So if you want to kind of work out if you're having a reaction to COVID-19 and got 3 other shots at the same time, it's very difficult to tell.
Perfect. Thank you, Dr. Ansell. And the next question is, which is the second to last one, Josh from Beaverton, Oregon. Any concerns about interaction of COVID vaccination and others with IVIG infusions? Dr. Ansell, any thoughts?
So I think one thing just to recognize is that IVIG infusions probably don't have antibodies to COVID-19 in them. Most of them the product was generated before most people were ill with COVID-19. So I don't think that there's going to be interaction in that direction. Could you have some other reactions to both of them? I don't think there's a very clear correlation with the one to the other. So I don't have any concerns. Could there be some interactions? Sure. But I would say, again, low likelihood that that's going to be a challenge. All I would suggest is just separate the two from each other by as much time as is appropriate for your care.
Oh, helpful. Thank you for the timing point. Dr. Castillo, anything to add before our last question?
Yeah, I agree. I don't have any issues with interactions. Actually, there is a position from I think it's the Infectious Disease Society, in which even the ASH, the Society of Hematology too, in which they said, COVID-19 and IVIG infusions, there are no concerns for interaction there.
Okay. Matt, I think Sheila from Germantown, Wisconsin is asking, should WM patients be vaccinated if they have recently undergone a stem cell transplant? Interesting. Dr. Castillo, thoughts?
Yeah, so I mean, obviously after a transplant, stem cell transplant, there is a series of vaccines that take place, usually 90 days after the transplant has been completed. So I don't see why not a COVID vaccine should be applied in that context as well, like any other vaccination. So probably the answer is yes. Okay. In that.
And I would agree with Dr. Castillo. Our transplant practice here will vaccinate you as long as it's been 90 to 100 days post-transplant.
That's right.
Okay. Before I ask you I want to be sure I've heard you correctly, because I've been taking notes as you've been going along, and thank you both for your clarity and for really driving home some critical points that are going to be my takeaways when I get up and move on with my day and share with my family and friends what I've learned today. So I'm hearing you both say, get vaccinated because some protection is better than no protection. And the risk of COVID is greater than the risk of the vaccines. And the risk-benefit analysis that we all need to do individually and personally, personal decision to be made with our own doctors, but it may vary from person to person depending on their specific WM case and how comfortable they are with risk more generally. Does that sound about right? And maybe we can say if there's a closing statement that you'd each like to say to build on any takeaways that people should be taking home today, Dr. Ansell. What are your thoughts?
So again, I really wanted to say thank you to the IWMF and to you for putting this on, because I think clarity and I think accurate information is critical. So I guess my plea to folks is be a critical reviewer of information when you get it. Just because Susie on your Facebook feed says something doesn't make it true. It may be true, but be someone who looks for multiple sources of information, because quite frankly, there is so much disinformation flying around that I think actually it's doing the health of WM patients a disservice. And so I would really, again, just say, seek out information from multiple sources that accurately reflect the situation. And quite frankly, one of the things I, as a researcher, find frustrating is when people will dismiss multiple thousand patient trials just because one person said something. And again, I would say you're hearing this from leadership in the country, trust the science. And I would say, again, for those of us that motivate for clinical trials, for cancer treatment for Waldenstrom's, the same is true in the space for vaccines. The same trials, same process, same methodologies are used. So if you can trust it for your cancer treatment, you can trust it for your vaccination. So I would make a strong case for trust the science, follow the science, and be a critical consumer of data and information. Don't pass on things that aren't accurate.
I love it. Thank you, Dr. Ansell. Dr. Castillo, any closing thoughts here before we are going to be wrapping up in a minute?
Yeah, no, I think that is a very way of summarizing what we have discussed. I think that is the way of looking at things in a critical manner. So we are not, we don't take an action because we are afraid of something, but rather because we understand something at a better level. I think that is a very important aspect of what we do. And we need truth be told. These vaccines were approved on an emergent use basis. These vaccines, we feel that they benefit the population much more than not. And there is, there's a choice, So if you feel comfortable and you understand the science and you think that is the right thing to do, the patient should get vaccinated. And we encourage strongly every patient to be vaccinated. Having said all that, it is a choice as well. If you, as a person, you don't want to be vaccinated because you think the risks are much higher than the benefits, that is a decision that you personally has to make. So I decided to take the vaccine. I discussed with my wife, who's also a physician, and she also took the vaccine. So that is a decision that we made together after weighing the pros and cons of the vaccination. So I hope this conversation we have had today has basically given enough information to people so they can take an informed decision. They can make an informed decision in terms of taking the vaccine, which obviously we encourage greatly at this time.
Thank you so very much. Heartfelt thanks again to Dr. Ansell and to Dr. Castillo for the work of their hands and the dedication of their hearts, and for their gracious participation in today's program. You both answered so many questions in so little time, and I'm so thankful. Day in and day out, you are true WM heroes, and we are grateful for all that you do on our behalf to improve the lives of all of us living with WM. Well, friends, our time together has flown by, but if you want to keep your connection to the IWMF roaring strong, hop online and join the conversation with WMers from around the world. Join us on IWMF Connect and Facebook. Check out a Zoom support group meeting. Pick up a phone and make a lifeline call. You can watch a past EdForm video or find a WM physician expert near you. Read an exciting new publication or scroll through the Torch magazine. All of this and more can be found easily and on demand from the comfort of your living room couch at IWMF.com. That's IWMF.com. Again, everybody join me in giving a huge round of applause to Dr. Ansell and Dr. Castillo. And we also want to thank our sponsors for today's webcast: Beijing, Selector Biosciences, Janssen Pharmacyclics, Treadway Foundation, X4 Pharmaceuticals, and last but not least, the IWMF is extremely grateful to all of you across the globe who have joined us today. Thank you for being with us and for being part of the international WM family. We hope that you enjoyed today's educational webinar, and I want to give a special shout out of gratitude to Glen Cantor, IWMF trustee, who analyzed 230 questions to collate today's list. No small task. Remember to check the IWMF events website calendar and watch for e-news announcing future global educational webinars. And we're going to see you all again very soon. But please complete the survey to let us know how we did today so that we can really improve tomorrow. From my heart to yours, warmest wishes for well-being on your WM journey. With the IWMF by your side, You are never alone. Thank you, dear doctors. I'm grateful beyond words. Thank you.